Good afternoon, everyone, and welcome to the Lynn Cancer Institute. Thank you for joining us for today's presentation on advances in breast cancer treatment options. We're honored to have with us today Dr. Michael Zeidman, Dr. Hilary Shapiro-Wright, Dr. Yosef Zeidin, and Dr. Angelina Tay. They are a distinguished team of physicians whose expertise spans oncology surgery, radiation oncology, and medical oncology. Together, they will share the latest developments in breast cancer care, including current treatment approaches, innovations in therapy, and strategies for improving patient outcomes. Their collective experience and dedication to patient-centered care not only enhances early detection, but also personalizes treatment strategies. We're so grateful to learn from each of them today. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, and the expertise of our staff, which we're seeing today, the benefit of our multimodality method of treatment, all combined will truly save lives. We invite you during this presentation to please take notes. And if you have a question, please put it in the chat box or the Q&A box, and the doctors will be able to address those questions at the end of their presentations. Now, please join me in a warm welcome to our first speaker, Dr. Michael Zeidman. Dr. Zeidman?
Good afternoon, everyone. My name is Dr. Michael Zeidman. I'm a breast surgical oncologist at Baptist Health City, serving the Boynton Beach area. And today I'm going to speak about, in my opinion, the most important innovation in the history of breast cancer diagnosis and management. I know that's saying a lot, but of course I'm talking about the screening mammogram.
Hey there. Dr. Zeidman, can you put your camera on, please?
Absolutely. Give me one second.
So we can see you now. There you go. Thank you.
Hello. Okay. So in the interest of time, we only have 10 minutes, so I'm going to move quickly, but this is a rundown of what I'm going to cover. So just starting from the beginning, breast cancer starts as one cell. One cell has a genetic mistake that the body does not detect that causes that cell to undergo unregulated cell growth. And the cancer cells basically double. They go from 1 to 2 to 4 to 8, etc. Each division takes days to weeks to happen. And by the time we can detect even the tiniest little cancers on a screening mammogram, it's already over 1 billion cells big. So I can comfortably tell new patients with a breast cancer diagnosis that they've had this cancer for months to maybe even years. Now, before screening mammogram, the only way to really tell if you had a cancer was you'd have to feel a mass, you'd feel a lump. By the time it's that big, now we're talking tens of billions of cells big. So these patients have had the cancer for years. And it's not the cancer in the breast that could kill you, it's if it travels somewhere else. So if they've had cancer for years, that's ample opportunity for it to metastasize. So the goal of screening is to catch the cancer as early as possible before it has the ability to do that. So one cell has a genetic mistake that leads it to have unchecked cellular growth. In other words, a cancer cell. This cancer cell will proliferate, and the body does its best to detect these cells and try to kill them, but at some point the cancer wins, and now we have a tumor. And if left alone enough over time, that tumor will figure out the ability to seed the bloodstream and metastasize, at which point it's too late to cure. Breast cancer is the #1 cause of cancer in women in the United States. I tell all my patients, if you live long enough, women who live long enough will get breast cancer. If men live long enough, they will get prostate cancer. But one thing you'll notice about all of these top 5 causes of cancer is that they all have to do with the linings of organs. So in breast cancer, it's the linings of the ducts, or in prostate cancer, the linings of the ducts of the prostate, the linings of the lungs, the linings of the colon. It's because these cells are constantly turning over, constantly dividing, giving enough opportunity for there to be a mistake that leads to a cancer cell. Now, if you look at the basic structure of a breast, about 70% of breast cancers are going to start inside the milk ducts. I tell patients, it looks like a stalk of broccoli. So the duct is the stalk of the broccoli, and the flower of the broccoli is the lobule. About 25% of breast cancers will start in the lobule. But the key point here is that it starts in the linings of these structures. Now, initially, once a ductal cancer begins and starts to proliferate, all the cells will be confined to inside the duct. This is stage 0 cancer or non-invasive cancer. We call it ductal carcinoma in situ, or DCIS for short. And at this point, the cancer does not have access to spread. It does not have access to the bloodstream or to the lymph nodes. And so the goal of screening is to catch the cancer at this stage before it has the opportunity to spread. You're not going to have symptoms if you have DCIS. This is completely an intraductal problem. Now, if left alone long enough, it will develop the ability to break through the wall of the duct. This is where we call it invasive cancer, and now it does have the opportunity to spread. Now, before we had breast cancer screening, we had the father of American surgery, William Halsted, who developed the radical mastectomy. He was under the false impression that breast cancer was a local regional problem. If we just remove it, problem solved. Now we know better. Now we know this is a systemic disease. And so these women were undergoing radically disfiguring procedures and having a modest benefit in their survival. Now, when it comes to screening mammograms, this is a technology that has its roots over 130 years ago with the development of the X-ray. In the interest of time, I'm not going to go line by line through this, but it wasn't until the 1950s where the mammogram started to be explored as a diagnostic tool. So these patients still had to feel a mass, and then we used the mammogram to confirm what we thought. It wasn't until 1970 where we have in my opinion, the most important trial in breast cancer history, which was the health insurance plan study out of New York that looked at over 30,000 women and divided them into 2 groups. One was the control group, where women underwent what was the standard of care at that time, which was just an annual physical exam. And then the experimental group received that physical exam, but also underwent annual mammography. Well, as it was no surprise, the experimental group had about a 50% reduction in 5-year mortality from breast cancer. This led to an explosion of countries across the world initiating their own screening programs, like Sweden, the UK started their national breast cancer screening programs. In 1987, in the US, we launched breast cancer screening programs that targeted underserved populations. Heading into the 1990s, we start to see digital mammography come into play. So patients no longer had to run to their surgeon with physical films in their hand. We were able to have high resolution images and send them back and forth through the internet to not have to actually be there to make the diagnosis, but they could be made remotely. You also start to see around this time controversies regarding what's the proper age to start screening. How often should we get screening? We run the risk of overdiagnosis if we screen too often. And the irony is these controversies still exist today, but hopefully after this talk, I'll offer some clarity on why I ascribe to the most stringent breast cancer screening guidelines. And now in the 2000s to present, digital mammography has become the standard, as has 3D mammography. This is where we don't just take a single film, we take multiple cuts through the breast to get a better idea of what's going on. This has improved detection rates and has reduced false positives. We are also, I would say in the last 5 years or so, starting to see the development of artificial intelligence assisted imaging. And this is not meant to replace radiologists, but it's used more as a tool, especially when it comes to lesions that can go either way. Should we biopsy? Should we not biopsy? Okay, so let's get into the meat of this. There are many different bodies out there that have come up with their own breast cancer screening guidelines, so it could get quite confusing. They range from very lenient to more stringent. If we're looking at the more lenient guidelines, that would be the US Preventative Services Task Force. They say start screening at 40 and go every 2 years. And then once you reach the age of 75, it becomes optional. I will discuss the reasons why they are recommending that patients follow this, but I got to say, I think it's garbage, pardon my French. Then we go to the American Cancer Society, so starting to get a little warmer. They say optional mammograms starting at 40, you can start at 45. And then once you hit the age of 55, you can go every other year. I think this is silly too, as the incidence of breast cancer increases as you get older, and the average age of developing breast cancer is actually 61, 62. So why would we get mammograms less often? And then you also have the American College of Radiology and Society of Breast Imaging. They're getting a little closer to what I recommend, starting annual mammograms at the age of 40. And if you're high risk, maybe even starting sooner than that. So which guidelines do we follow? I feel strongly that the most appropriate guidelines to follow are with the American Society of Breast Surgeons. I'm not saying that just because I'm a breast surgeon. I truly believe this is the way to go. Once you reach the age of 25, you should have a formal risk assessment by your primary care doctor to put you into one of two groups. Are you either average risk or are you high risk? So if you have things like family history or prior chest radiation or even genetic testing that puts you in the high risk category, that's where you belong. Now, if we're talking about just average risk women, start annual mammograms, so every year at the age of 40 and continue as long as you are in good health. If you are high risk, you may have to start even sooner, as early as by the age of 30, and we may have to add screening MRI. MRI is a more sensitive test than the mammogram, and they work synergistically. Now, about 50% of women have dense breasts. This means two things. Number one, you're at a slightly increased risk of developing breast cancer. But more importantly, number two, it's harder for us to detect cancers on a mammogram. So if you have dense breasts, you should also consider getting supplemental screening ultrasounds with it. So why do I not agree with the USPTF guidelines for screening every other year? To their point, survival is unaffected by whether you go once a year or once every other year. You reduce the risk of having a false positive, which can lead to unnecessary biopsies and anxiety. And of course, there's increased costs with going every year. But what they don't take into consideration, or I should say, the only thing they take into consideration is survival. They're not looking at what the patient actually has to go through to get them to the point where they're cancer-free. If we do more frequent screening, we can detect the cancer earlier, which can result in fewer lymph node surgeries, less need for aggressive systemic therapy, less of a need for removing the entire breast or mastectomy. We could do something called a lumpectomy if it's caught soon enough. And radiation may be minimized or avoided altogether if we catch it early. So on the subject of survival, if we catch the cancer at stage 0 or DCIS or stage 1, survival approaches 100%. That's the goal of screening. So that's why I feel strongly that we should ascribe to annual screening, not every other year. If we catch it at stage 2, and as you could see, stage 3, and heaven forbid, stage 4, the 5-year survival rate drops precipitously. Screen detected cancers are going to be smaller, they're going to be lower grade, they're going to have less of a chance to spread, which results in lower treatment burden, higher cure rates, and improved quality of life. And this has been well established on very large trials in many different countries. Early detection allows us to avoid having to do a mastectomy or removing all the lymph nodes under the armpit, which could have disfiguring consequences. It reduces the need for chemotherapy. It lowers emotional and financial stress. So the bottom line is this, and I hope I came in under 10 minutes. If you are 25, you need to get a risk assessment done by your primary care doctor to see if you're average risk or high risk. If you're average risk, make it simple. Annual mammograms starting at the age of 40. If you have dense breasts, add an ultrasound to that. If you're high risk, you may have to start sooner with mammograms and add MRI. Thank you.
Thank you, Dr. Zeidman, very much. Dr. Shapiro-Wright?
Thank you so much for having me. This is my 6th year being able to participate. So I appreciate the opportunity and welcome to everybody. I am going to talk about axillary management in patients with breast cancer. Today, we're going to discuss lymph nodes and their function. We'll define the evaluation and evaluate the different axillary procedures that we use and the techniques we use to evaluate axillary lymph nodes. Discuss how we select patients for axillary evaluation and key changes that we have experienced most recently related to axillary surgery. So what are lymph nodes and what do they do? I get this question very frequently from patients. Axillary lymph nodes are filters. They're tissue, when we talk about breast cancer, most commonly in the axillary or underarm area. In later stage breast cancers, they can affect other regions such as above and below the clavicle, the inside of the breast, and what we call the internal mammary chain lymph nodes behind the pectoralis muscle. But for early stage breast cancers, we really focus on those under the arm. The average patient has anywhere from 20 to 40 lymph nodes, and they act as checkpoints for lymphatic fluid. So lymphatic fluid drains through the breast, and it drains with cancer cells, and then the lymph node acts as a filter to trap those cancer cells to prevent them from spreading. And when those cancer cells get trapped in the lymph nodes become swollen and they can be felt or palpated. We can also see abnormal lymph nodes through imaging. So the axillary lymph nodes are commonly the first place cancer spreads or moves when it goes beyond the breast. The status of the axillary lymph nodes is important for us as physicians. It helps us determine stage, prognosis, and can affect the therapeutic options related to surgery, radiation, or systemic therapies based on their involvement of the lymph nodes with cancer. Historically, we're going to talk about the de-escalation of therapy, but historically, axillary lymph node dissection or removing all of the lymph nodes was the standard of care, regardless of the type of surgery that the patient had for the breast, regardless of the type of cancer the patient had in the breast, and regardless of the biology of that cancer. Today, we talk about going as far as omitting lymph node evaluation in select patients. We can use imaging studies such as MRI or ultrasound, as well as clinical exam. We do have clinical prediction models, most commonly those that were established through Memorial Sloan Kettering Cancer Center and MD Anderson, that use characteristics not only of the cancer, but also of the patient to help detect, one, if the patient will have a positive lymph node, and two, if the patient is found to have a positive lymph node, the likelihood of having additional positive lymph nodes and requiring additional surgery. We also take into account the tumor's biomarkers, meaning its susceptibility or how it is affected by estrogen and progesterone, as well as how it is affected by a protein called HER2, the grade of the tumor, and other biological characteristics that are found by by tools such as Oncotype. So what's the difference in axillary node dissection, sentinel lymph node? What does this all mean? So an axillary lymph node dissection or axillary lymphadenectomy is a surgical procedure completed which removes all or most all of the lymphatic tissue under the arm. We know that this has a high rate and a high risk for complications. The most common thing that we hear patients concerned about is lymphedema or arm swelling, which commonly can occur after having a lot of the lymph nodes removed, but it can occur with just a few lymph nodes, but less likely. Other complications include pain, axillary scarring in two types, one called cording or web syndrome, paresthesias, numbness, damage to nerves and vascular structures under the arm area, shoulder dysfunction, range of motion issues, and scapular dysfunctions, especially something called winged scapula. With positive lymph nodes, patients tend to go on to receive radiation to the armpit area. And this, combined with the axillary dissection, can cause a significant increase in the risk of what we call morbidities, or these complications. With patients undergoing full axillary dissections and the addition of radiation to that axillary region, the risk of complications such as lymphedema can be as high as 40 to 50%. Lymphedema, or the one that most patients ask about and are most concerned about, is caused by an improper drainage from the arm due to removal of the lymph nodes which drain the arm, and you can't decipher what's draining the arm and what's draining the breast intraoperatively, and so all of the lymph nodes are removed. More commonly now, we do what's called sentinel lymph node biopsy as the first step to evaluate lymph nodes under the arm at the time of surgery. It is thought that the lymph nodes are in a chain, and if you can isolate those at the lowest point of the chain and they don't have evidence of disease, then there's no need to take out any lymph nodes beyond that, because those should be negative as well. The way a sentinel lymph node biopsy is performed is that dyes, either a radioactive dye and or a blue colored dye, or both, are injected into the breast before surgery. Those dyes travel through the dermal lymphatics of the skin and deposit in those sentinel or gatekeeper lymph nodes at the bottom of the chain. Surgically, an incision is made most commonly in the underarm area, and those lymph nodes that pick up those dyes, or what we call hot spots, whether they have radioactive dye, blue dye, or both, are removed from the underarm, and they are sampled. Commonly, it's between 1 and 4 lymph nodes that are removed and sampled. And if they are negative, we can eliminate doing any other further surgery in the armpit area or the axilla, decreasing the risk for morbidities or complications significantly. So the evolution and management of the axilla, as I stated, initially was axillary lymph node dissection, which caused disfigurement to the axilla, high complication rates such as lymphedema, scarring, and range of motion issues, and therefore caused long-term issues to the patient. We then transferred to what we call sentinel lymph node biopsy in the 1990s. Subsequently, we then transferred to sentinel lymph node biopsy alone and only completed axillary node dissection in those patients who had positive nodes. We further went on to eliminate the need to complete axillary node dissections in patients in selective patient populations, and now we talk about omitting lymph nodes in some of those patients. So here's a depiction of some of the time frames in which things have occurred. So as I stated, in the early 1990s, the evolution of sentinel lymph node biopsy was established, but this was initially used only for patients who were considered clinically node negative prior to surgery, meaning that the patient had no positive lymph node biopsy preoperatively, no systemic therapy, meaning chemotherapy, prior to any surgery. They had no imaging abnormality on lymph node evaluation, and they did not have any clinical evidence or on exam of having lymph node positivity. Sentinel lymph node biopsy would be done at the time of surgery, and if lymph nodes were negative, no further surgery would be completed. However, if lymph nodes were positive, axillary lymph node dissection was then completed. We've de-escalated that therapy then to state that patients who had only a few in select patient populations, meaning 1 to 2 positive lymph nodes, didn't need axillary node dissection any longer, but could be treated with radiation, and we could de-escalate that surgery, therefore de-escalating risk. We then went on to say that sentinel lymph node biopsies could be used in patients who did have positive lymph nodes prior to surgery, but had undergone therapies like neoadjuvant chemotherapy that took them from a patient who was clinically positive to a patient who was clinically negative. And by that, I mean that prior to surgery, after the administration of their preoperative therapy, you no longer could feel a lymph node under the arm, and you could no longer see an abnormal lymph node on imaging, meaning that they had become clinically node negative. If sentinel lymph node biopsy was completed and at surgery, lymph nodes were confirmed to be negative, then they did not need to go on to axillary dissection. More recently, studies have been published that we're going to talk about in how we can select patient populations that we can completely omit lymph node evaluation at the time of surgery. So recent trials have shown that omitting sentinel lymph node biopsy is oncologically safe for select patient populations. This results in lower rates of complications and improved quality of life for the patient. Two specific trials that I'm going to mention, which are the largest trials that we use, are the SOUND trial and the ENSEMA trial. These trials were trials used for patients who were small tumors. For the SOUND trial, tumors were what we call T1, or the smallest size less than 2 centimeter trials. For the ENSEMA trial, they allowed patients up to and including 5 centimeters. Patients are ER positive or hormone receptor positive, clinically and radiologically had no negative disease, and most commonly the patients were postmenopausal and over 50, but in the SOUND trial, they looked at patients as young as 40. So these trials were what we call non-inferiority study trials, meaning they wanted to know if the sample group or the omission group showed inferior results to the standard of care or sentinel node biopsy. Again, there were patients for the SOUND trial with early stage T1 lesions, meaning these lesions were less than or equal to 2 centimeters. This was completed in Italy, Spain, Switzerland, and Chile. There was just under 1,500 patients enrolled. This study randomized patients in a one-to-one fashion, and it evaluated women for the omission to find out if the omission was inferior to sentinel node biopsy, and it had a follow-up of 5 years. So these are the results. And as you can see, local regional relapse, distant disease, meaning disease found outside the breast or axillary region, deaths, 5 disease-free survival, distant disease-free survival, and overall survival were basically exactly the same in the two groups, regardless whether lymph node surgery was completed as a sentinel node or if it was omitted. So what that means is that when they looked at someone's overall survival, whether they had cancer back at all and or cancer back distantly, it was exactly statistically the same for both groups, showing the safety and omission and the select patient population with early stage breast cancer. So the ENSEMA trial was done basically the same, although it allowed women to have lesions that were bigger, up to 5 centimeters. It enrolled about 5,500 patients. These patients were randomized a little bit differently because this trial went on to look at a different avenue, meaning the second part of the trial looked at sentinel node biopsy positive patients, whether they could complete the sentinel node alone or the addition of axillary node dissection, and they needed the larger patient population for that. So that was enrolled with less patients, but it still was over 1,000 patients in the sentinel lymph node biopsy, in the no sentinel lymph node biopsy group. And again, they looked at omission with a non-inferiority aspect at 6 years follow-up. So we're going to look at just that first part of the study because that was the study looking at who could be omitted. And again, if you look at this data, the 5-year disease-free survival is statistically equivalent. Axillary recurrence is within 1%. Again, death within 1%, invasive local regional recurrence, meaning that cancer came back in the local regional area within 1%. Distant recurrence was exactly the same. So again, showing that in select patient populations in this group, even with tumors that are larger, stage 2 tumors, because they're bigger tumors, it was safe to omit sentinel lymph node biopsy with favorable pathology of a tumor, meaning it was ER positive and HER2 negative and a lower grade tumor. This study also looked at risks related to lymph node surgery and found significant difference, almost 4% difference in the rate of lymphedema. Obviously, patients having surgery would have a higher risk, and shoulder range of motion dysfunction was much higher in the sentinel lymph node biopsy group. So what's the overall take home? De-escalation therapy is safe, but it's safe in select patient populations. This is not a one-size-fits-all approach. You should discuss the options, and if you are a patient with breast cancer, if you are a patient who can have omission of axillary surgery, you should discuss that with your doctor. This is definitely a combined decision, especially we do this in our program. Our patients go through our multimodality clinic, and one of the discussions we have for patients who are felt to be candidates for omission is a multimodality discussion if it is going to impact any of the other modalities with what happens in the axillary region. So it's not just a decision by the surgeon, it's a multidisciplinary approach to the care of the patient. And just like any other field of cancer, surgical procedures and treatments are always changing for breast cancer. Thank you.
Thank you. Dr. Zaiden?
Good, great. Well, good afternoon, everybody. This is one of my favorite meetings every October. Thank you for joining. So my name is Yusuf Zaiden. I'm a radiation oncologist at Lynn Cancer Institute, and I'll be covering some updates as much as time allows on radiation therapy. No disclosures. So some figures which have been already alluded to, breast cancer is still a major problem in our battle against cancer in general. It's still the leading cause of cancers in women, with 330,000 cases estimated in new cases per year. And then in terms of mortality, it's the second cause of mortality in women, as shown here. In Florida, actually, in 2024, it was the third leading state in terms of breast cancer incidence amongst all the other states. So California was first, then Texas, then the state of Florida. These are some curves. The curve on the left side shows, in general, the incidence of breast cancer in women as compared to other kinds of cancers. And you could see that since approximately 2003 and later, there's been a slight tick up in the incidence of breast cancer. And at one point, we thought that maybe the increased incidence of breast cancer is perhaps related to increased use of mammographies and people being a little bit more cautious with screening. However, it turns out that this 0.6% annual increase that we are seeing since 2003 is not related to an increase in screening. However, unfortunately, it is related to an increase in obesity rates and decreased fertility, which are risk factors for breast cancer. The curve on the right-hand side, and this is probably a more important curve, is the mortality of breast cancer. And fortunately, if you look from the 1990s until the 2020s, the mortality from breast cancer has been trending down, and that's mainly because of improvements in therapies and improvements in our tools and clinical trials. So as alluded to, the price of a cure has not always been easy, and women had to pay a very hefty price back in the 1800s. This is Sir William Halsted, who propagated the so-called Halstedian mastectomy, which is disfiguring. I can't agree more with what Dr. Zeidman said. Disfiguring surgery, very, very aggressive surgery that entails removing the whole breast tissue, the pectoralis muscles, and the axillary tissue. And you could imagine how a person would look like after this radical surgery. Fortunately, for clinical trials, we learned with time that we could really achieve very excellent survival from breast cancer without doing such a radical surgery. And this is only made possible by clinical trials like this one, NSABP06. That's a paradigm that introduced a paradigm shift in the management of breast cancer. So what Bernie Fisher and colleagues did back in the 1970s and 1980s, they asked the same question: do we really need to do such a radical surgery? So they took around 1,800 women, stage 1 or 2 breast cancer, and they randomized them to either having the mastectomy or a smaller surgery called lumpectomy, where that entails taking just the breast tumor with some margin around it, or the third randomization was doing lumpectomy followed by radiation therapy. What they found out, and this is a trial that we have one of the longest follow-ups on, is that the survival of these women was essentially the same. You could look at the overall survival curves, they're almost overlapping. However, the big difference is, if you look at the curve on the right side, those women that had the lumpectomy alone had a much higher rate of disease recurrence, than those that had lumpectomy followed by radiation therapy. In general, we say that radiation therapy reduces the chances of a recurrence by approximately 2/3. So there has been multiple trials all around the world, similar to NSABP06, that again showed the same message. And this is a meta-analysis from early breast cancer trialist group that again shows on the curve on the left-hand side, showing that adding radiation therapy lowers the rate of recurrence. And if you follow these women long enough, up to 15 years, you start seeing that decrease in disease recurrence translates into lower breast cancer death by approximately 3%. So that is really meaningful. So that when you're preventing breast cancer recurrence, you're also translating that into survival from breast cancer long term. So, however, as alluded to, not all breast cancer radiation therapy treatments are created equal. And we have come a long way with our techniques and schedules for radiation therapy. So I'm going to start with the first part of this diagram here, the lower end of the spectrum, where women undergo surgery and no radiation therapy is needed. 0 days of radiation, 0 gray of radiation is needed. And this is possible for patients that have a very favorable outcome, small ER-positive tumor, whether invasive or DCIS, and they're willing to take endocrine therapy for 5 years. The rate of disease recurrence is very, very small, and the benefit of radiation therapy is non-significant, and we can omit radiation therapy in those patients. Then we come to the next schedule, partial breast radiation therapy. And this is a newer schedule in our tools. And that essentially entails taking radiation therapy over 5 days or 1 week of treatment. And again, this is reserved for overall favorable cases that are node negative, that have widely negative margins, more favorable histologies. And again, the outcomes here are excellent local control, and we only need to treat that surgical tumor bed with a margin, and the patient can be done in 5 days, and then they can resume whatever things they want to do afterwards. Okay, then we go to a more escalated radiation therapy courses, the whole breast radiation therapy. And this is, again, for patients that have either more aggressive biologies or for patients that don't fit the criteria for partial breast radiation. And for whole breast radiation, again, the treatment is very specific to the breast tissue, and that is typically done over a period of either 1 up to 4 weeks, depending on the specific case. At the far end of the spectrum are for patients that require more extensive radiation therapy treatments, and those that require breast and lymph nodes radiation therapy, specifically for those patients that have either involved axillary lymph nodes or involve internal mammary supraclavicular lymph nodes. And these tend to take more time, between 3 to 5 weeks in some cases. So how do we deliver radiation therapy? And again, there's been a revolution in the world of radiation therapy in terms of the technologies used. And fortunately, here at Lynn Cancer Institute, we have multiple platforms that are available for treatment to choose from. So we have modern Linacs. TrueBeam is one of them that is available in all of our 3 sites in Boca, in Delray, and in Boynton Beach. We have a tomotherapy unit, or also called the Radixact unit. And this unit is very helpful for treating more extensive areas like the breast and the lymph nodes. And then we have a CyberKnife unit as well that we sometimes use in order to treat stage 4 cases or brain metastases. How do we choose when we have options, for all these treatment platforms? How do we choose? So it's very important to consider these 3 factors in the choice of the appropriate platform and schedule for the patient. What do I need in order to cover the area that is at risk for disease recurrence? So target coverage. What's the specific patient logistics? Patients might have restrictions into where they're able to go for treatment geographically. What are the normal tissue constraints? What normal tissues are around the area that I'm treating with radiation? All these factors interplay in order for us to choose the appropriate platform. So ideally, we really want to be in that sweet spot where we're using a treatment that has the lowest incidence of complications and the highest rate of cancer control, so-called therapeutic index. This is a challenge. I decided to give some examples, make this a little bit more real life. So this is a patient that underwent lumpectomy, and clearly you could see on her CT scan, there are some clips, surgical clips medially, because this was a medial tumor. And then they come to us and they need whole breast radiation therapy. Now you could see the challenge here is that the organ in red is the heart. And now we need to deliver radiation therapy for this left-sided breast cancer without doing excessive dose to the heart. So actually, there's been a very good study documenting that there is an increased rate of major coronary events with time. For every gray of radiation therapy, we increase rate of complications or cardiovascular events by 7.4%. So that's for every gray to the heart. So how do we kind of like work around that challenge in order to treat the breast and yet avoid the heart? One technique that we have available at Lynn Cancer Institute is the breath hold technique, where essentially the patient lays supine and takes a deep breath in. And that gives us the advantage of having the lungs kick in, and that air pocket that's created between the breast and the heart is to the advantage of the patient. And that allows us to safely treat while avoiding the heart. And with that technique, there's been multiple studies showing that you can reduce the mean heart dose by 50%. That's one way. Another way we could do this is using the prone technique, where essentially the patient is laying down on a specific prone breast board like this one shown in pink. And we could do the treatment safely by isolating the breast and using gravity to our advantage in order to isolate the treatment area and avoid the heart at the same time. So I do want to talk for a few slides about the latest technology that we have available. This is the latest addition in terms of units to our armamentarium. This is the MR-guided radiation therapy that was added in 2022 at our Delray site. So the advantages of using MR-guided radiation therapy is that it gives us superior soft tissue delineation as compared to CT-guided therapy, like the other platforms I spoke about, or X-ray guided therapy. It can also allow daily adaptive replanning, and it does allow us for target dose escalation, more sparing of normal tissues, and we could assess motion while on treatment. So I'll give an example. This is a 70-year-old patient that has metastatic breast cancer to the liver. And she has only one lesion in her liver and came to us for treatment. You could see on the CT scan a fusion between the CT and the PET scan, and you could see the area that's lighting up. This is the area that she has metastasis proven by biopsy to the liver. We discussed it on the tumor board, and the decision was to go after this area with radiation therapy. Well, luckily, we have this MR-guided platform where essentially where the patient is laying on the table, we can see live the tumor moving. And then when the patient takes a deep breath in, we could isolate this treatment to be in our radiation beam target, and then we could treat it safely with 5 sessions of radiation. And the patient now is in follow-up, and the liver is free of tumor. So this wouldn't have been possible without having an advanced platform with MR-guided radiation. Okay. So we have another big technology that is coming up to us, and you might have seen ads and construction going around at our Boca site. This is proton therapy. This is expected to open in 2026. Already the gantry and the cyclotron are in the building. It's going to be a beautiful building. I'm sure there will be an announcement and the grand opening when it opens in 2026. This is what's going to look like. This is from our sister institution, Miami Cancer Institute down in Kendall. Hopefully it will look very similar to this. But so what, we get asked this a lot. What are the advantages of proton therapy? So the advantages of proton therapy are essentially related to the Bragg peak, which is a biophysical property of proton therapy. So on this graph, you're seeing two curves. The orange curve is the curve for proton therapy, and the gray curve is for X-ray therapy. So you could see with photon therapy or X-ray therapy that the dose is deposited at a depth, and then it slowly fades away, what we call an exit dose. Whereas with proton therapy, because the charged particles, they have this virtue of having the Bragg peak. And that is to our advantage, where essentially we can use that Bragg peak to centralize it around the tumor or at-risk area. And then there is a sharp dose fall off right after the Bragg peak, meaning there is very minimal dose that goes to the normal tissues around it as compared to photon therapy. I'll give a few examples where this is advantageous. So again, with proton therapy, we have the advantage of improved normal tissue sparing. We can dose escalate because the normal tissues are getting minimal dose. It also decreases the late morbidity because the normal tissues are also not being exposed to excessive radiation. And it gives us the advantage of targeting larger target volumes. This is, for example, one case where the radiation oncologist needs to treat the breast and the nodal chain called the internal memory nodal chain. It also happens to be on the left side. The patient had a left-sided breast cancer. You could see the challenge with photon or photon electron therapy. There is still a good amount of dose that is going to the heart and to the lungs. The advantage with proton therapy shown on the far right-hand side is that the dose stops after it travels a certain distance in the body. And that is a major advantage for sparing the heart and sparing the lungs excessive dose of radiation therapy. So we're really excited for having this technology. Again, it's not for everybody, but for the right patient, it's fantastic to have such a tool available. Another case scenario where proton therapy can be advantageous is for patients that have so-called leptomeningeal disease. Some patients do have a brain involvement from breast cancer when things are advanced, and they have evidence of disease in the so-called cerebrospinal fluid. And for those patients, we need to deliver leptomeningeal or craniospinal irradiation. And this is really a very big field, as you could see in the diagram here, that entails treating the brain and the spinal canal in its entirety. So you could see with proton therapy how the dose nicely stops right in front of the vertebral bodies, whereas with photon therapy, you have this exit dose that goes to the anterior organs. So actually, there's been trials showing a survival benefit for using proton therapy in these case scenarios. Okay, I did mention a lot about clinical trials, and I think we are really fortunate to have clinical trials open at the Lynn Cancer Institute. At LCI, we're part of the Energy Oncology Network of cancer centers, and we have, I do want to mention a couple of clinical trials that are available for patients from a radiation perspective. The first ongoing trial is called the Taylor RT clinical trial. And this is for women with estrogen receptor positive breast cancer that have 1 to 3 positive lymph nodes and have a low oncotype. And essentially, the randomization here is, do we really need to treat all the regional lymph nodes, or can we just get by treating the breast only with this trial? So it's a very important question for select patients that have a more favorable node positive disease. Another trial that we have open is the Brazil trial, and this is an in-house physician investigator-initiated trial. This is a breast re-irradiation after second ipsilateral lumpectomy. This is for patients that experience a second same breast event during their lifetime after having prior breast radiation therapy. So we are investigating repeat breast lumpectomy and re-irradiation. And again, this is selecting a certain profile of patients with favorable tumors, but it is available at LCI as well as Miami Cancer Institute. In summary, I do believe that having diverse radiation therapy platforms is key for delivering cutting-edge radiation therapy. The technological advances that happened over the past 2 decades in radiation therapy allowed us to deliver more safe, more accurate, and more effective treatments. Yet the selection of the appropriate treatment schedule and target is a very extended decision-making process that is done with the specialized radiation oncologist. Proton therapy, I believe, will have several advantages down the line, and we're really excited to have the technology available for us for the right patients, clear dosimetric advantages, and we have many randomized clinical trials that are looking at the advantages of proton therapy that we're also looking forward to. And please consider enrolling on clinical trials when approached to, because this is the only way we could move our field forward. Thank you.
Thank you so much. Dr. Tay?
Welcome everybody. My name is Angelina Tay. I'm a medical oncologist here at the Lynn Cancer Institute in Boca. My topic today is going to be updates in metastatic breast cancer. So this is an overview of my discussion today. I'm going to review what is metastatic breast cancer, how is it defined, rates of metastasis based on subtype of breast cancer, survival implications, and then I'm also going to briefly review some of the American Society of Clinical Oncology highlights presented this year. There was a heavy emphasis in the breast segment of ASCO at the ASCO meeting on treatments for metastatic breast cancer, which was nice to see. So metastatic breast cancer basically refers to when breast cancer has spread from its original location to other sites in the body, more distant to the breast. It is often referred to as stage 4 disease. Unfortunately, in rare exceptions, except in rare exceptions, most cases are incurable. However, the course of disease can be quite heterogeneous. Some cases of metastatic breast cancer follow a very aggressive course that tends to be unresponsive to therapy or only responsive for short durations, whereas there are other types of breast cancer that can behave more slowly, more indolently, and respond to various therapies over the course of many years. In general, the subtypes of breast cancer most likely to metastasize are the ones that we think of that are more aggressive, the triple negative and HER2 positive subtypes. Not far behind is the so-called luminal B subtype of breast cancer, which is typified by typically hormone sensitivity, but more aggressive features. Typically, there's low expression or negative expression of the progesterone receptor, and it's typically associated with a higher grade and proliferation rate. And then further behind is luminal A, which is a more favorable type of breast cancer, typically quite hormone receptor positive and HER2 negative, usually low grade and low proliferation rate. So thankfully, the incidence of metastatic breast cancer is decreasing. This is in part due to improved treatment options that we now have for early stage breast cancer and improved supportive care that allows patients to remain on treatment rather than have to discontinue treatment prematurely. So they're able to receive that entire intensity of the prescribed treatment. Survival in metastatic breast cancer is measured in years. This is in contrast to some other cancers that we think of, some lung cancers and GI cancers, where survival is often measured in months. But breast cancer is a type of cancer where we often see people living with this disease for years. As I mentioned a couple slides ago, this disease can be very heterogeneous. So it's very common nowadays to see patients with metastatic breast cancer often living beyond 5 and sometimes over 10 years. It's looking more hopeful as time has gone by. So I just wanted to very briefly review 3 trials that actually covered different subtypes of the 3 main different subtypes of breast cancer that were presented at this year's ASCO conference. The first trial was the ASCENT-4 trial, which looked at metastatic triple-negative breast cancer. This was a phase 3 randomized trial evaluating a drug called sacituzumab govitecan plus a form of immunotherapy called pembrolizumab versus our current standard of care, which is chemotherapy plus pembrolizumab for patients who have PD-L1 positive metastatic triple-negative breast cancer. So what does that mean? So I'll try to break this down. So sacituzumab govitecan is a special targeted form of therapy. It's a type of drug that's on a growing list of special drugs called antibody drug conjugates, where the drug is delivered specifically to cancer cells that express a protein on the surface called TROP1. And it turns out that many breast cancers are enriched in TROP1, so it delivers the active ingredient, the active compound, directly to the cancer cell. The active compound in this drug is called SN38, which is an active metabolite of a commonly used drug called irinotecan. Pembrolizumab is a form of immunotherapy that harnesses the patient's own immune system to fight the cancer, and was again studied in patients with triple-negative disease who were PD-L1 positive. PD-L1 is a protein that plays a very important role in stimulating the immune system to recognize and fight the cancer. So compared to the standard of care, the standard arm of chemo plus pembrolizumab, there was a significant improvement in what we call progression-free survival, the time of the duration of time essentially that a patient is on therapy without experiencing cancer progression. And it was approximately 3 to 4 months, and it was a statistically significant difference. This appears to be set to supplant the current standard of care. I think there may be some challenges, though, in adopting this, principally because this was a study that took place when the more widespread adoption of neoadjuvant chemoimmunotherapy took place. Only approximately 5% of people in this trial received neoadjuvant chemoimmunotherapy. So it's difficult to translate whether a patient who did previously receive chemoimmunotherapy, whether they would have the same good results if they developed metastatic disease afterwards. But the results are the best that we've seen so far in the first-line setting for triple-negative disease, and is likely to change our practices in the future. The second trial that I wanted to talk about was the Destiny Breast 09 trial. And this was a trial that focuses on metastatic HER2-positive breast cancer. So this was a study that looked at the combination of a drug called trastuzumab deruxtecan plus pertuzumab. Trastuzumab deruxtecan is another antibody drug conjugate, which delivers the active compound to cells that are enriched in HER2, plus pertuzumab, which is an antibody directed against HER2-expressing cells, versus our current standard of care, often known as the Cleopatra regimen, which includes taxane chemotherapy plus 2 antibody-directed therapies, trastuzumab and pertuzumab. And this was given as first line for patients with HER2 metastatic breast cancer. And this improved the median progression-free survival from approximately 26.9 months to 40.7 months. And this is the longest progression-free survival that we've seen in patients with metastatic HER2 positive cancer in the first-line setting, and the difference was statistically significant. There are some considerations here as to whether this can also be adopted widespread. One of the main considerations is that in the Cleopatra regimen, which is the taxane plus trastuzumab plus pertuzumab arm, this regimen is designed that you can drop the chemotherapy after 4 to 6 cycles and then proceed with just the antibodies alone. So it cuts down on a lot of long-term toxicity. Whereas in this particular trial, the trastuzumab deruxtecan continued indefinitely until there was disease progression. The side effects of this particular drug are not minimal. It can be associated with a lot of fatigue and nausea. And so there are definite quality of life concerns that have to be considered when considering this protocol. We also don't know what the contribution is of pertuzumab to trastuzumab deruxtecan. There was a monotherapy arm in this study looking just at trastuzumab deruxtecan, but we don't have those final results yet. And then the final trial that I just wanted to review was the SERENA-6 trial, which looked at metastatic ER-positive, HER2-negative disease. This was a phase 3 trial using circulating DNA surveillance by serial blood analysis to detect a special type of mutation that occurs in breast cancer cells after long periods of treatment. The ESR1 mutation often predicts resistance to an aromatase inhibitor, which is often used as a first-line therapy for patients with metastatic hormone-sensitive breast cancer. So upon emergence of this mutation, patients were randomized to a special oral medication, non-chemotherapy drug called camizestrant. This is a drug that works as a selective estrogen receptor degrader. It's a complete estrogen receptor antagonist. And it compared those patients to continuing standard therapy before radiologic progression. What's intriguing about this trial is that this is sort of a new age concept of using molecular surveillance to determine when to switch therapy. Historically, we always used clinical signs or radiographic signs of progression before switching therapy. But this is looking at switching therapy even before we see radiologic progression. And lo and behold, it did show that there was a 56% reduction in risk of progression or death when you use this type of method of surveillance. And there was greater median progression-free survival with molecular surveillance versus standard surveillance. The study is still very preliminary. Only a small number of patients in the total volume who have enrolled have been analyzed so far, but the early results are very compelling. And I think as technology is advancing, we may be moving in this direction of using molecular surveillance rather than traditional methods such as clinical exams and radiologic studies. The other major impediment, of course, in applying this sort of strategy now is that camizestrant right now is not yet FDA approved. So there's still a lot to be learned from this trial, and we'll be eagerly awaiting the final results. So conclusions from my talk, metastatic breast cancer essentially means cancer has spread beyond the breast to distant organs. The course of metastatic breast cancer may vary from very slow to very aggressive. Triple-negative breast cancer is the most likely subtype to metastasize and is often associated with the shortest survival rates compared to other subtypes of breast cancer. Hence, this is why we often treat very aggressively up front in order to try to optimize the chance for cure in the earlier stages. There are new studies presented at ASCO this year that show promising new strategies that may improve outcomes for the 3 primary subtypes of metastatic breast cancer. And that's the end of my talk. Thank you.
Thank you so much. Doctors, each one of you, we can't even imagine how much research and time goes into putting these presentations together, plus taking the time to deliver it to us. So thank you so much. It doesn't look like, are there any questions? There's a thank you in the chat box. And this was awesome. So the education was really phenomenal, and we appreciate you so much. So much was covered that I'm sure there are not many questions, as we can see. But luckily, this presentation was recorded. So anyone that's was able to attend, if you want to review it again, if you have people that you'd like to share it with, the edited presentation will be available probably the beginning of next week. And Lee will be sending out an evaluation. And we really appreciate when you respond to that. And at that time, you can also request a copy of the presentation, and she'll send you the link. It looks like we have one question. I don't know if the doctors can see it, is what are the considerations for alternative forms of therapy, such as hyperthermia therapy?
Yeah, I can take that. Yeah, thank you. This is a very good question. So the use of hyperthermia, there is some good evidence that it can be helpful to make the radiation more effective, specifically in cases that are recurrent or more aggressive breast cancers. We don't use it in the upfront setting. However, in the recurrent setting, in order to make the radiation more effective, it can be considered.
Okay, are there any other questions? I don't see any others. We appreciate everyone who has joined us today. Doctors, thank you. We want to remind everybody, as we all know, October is a very robust month of education and activities and events. October 25th, the American Cancer Society holds their Making Strides Against Breast Cancer. If anyone would like to join our team, we're the LCI Guardians. And the month of November, on November 5th, we'll be presenting on pancreatic cancer. November 12th on lung cancer. November 19th will be our nutrition presentation on bone health. And a little promo on November 8th. Our department is going to be hosting a holiday gift bazaar, which will be a fundraiser for our League of Ribbons. So thank you, everyone. Thank you, doctors. Happy October and have a great weekend. Thank you for joining us.